So these are we start to have results. The cytology reveals macrophages and a few neutrophils and lymphocytes. CBC is okay. Serum biochemistry, it's also fine, no big changes. And here we have a serology for leishmania, which is positive. It's a weak positive, which is good news. In general, it's good to do a quantitative serology because we know that the titer is quite related to the severity of the disease. When the dogs have a very high titer, they usually have a very weak immune response. So in the dogs with a good response, they have a low titer and a very good T-cell cellular response. The dog with a weak cellular response, they produce antibodies that are not helpful and in controlling the disease, but they give you information showing this response is inefficient. This dog is going to have a very severe disease. The antibodies, instead of controlling the disease, what they do is they cause kidney disease, articular inflammation, and uveitis, so they do not help. They create more problems. Serum protein is not terrible, 7.4, so it's good. This is the cytology. In many cases, you will not see the leishmania. So here there is no leishmania, just macrophages, few neutrophils, lymphocytes maybe, but we don't see the parasite. That happens in many cases. So only the serology helps you to suspect that this is the case. This is this dog, total protein 7.4, not too bad. So albumin is good. We are not losing albumin, good news. The urea analysis was good. So we are just narrowing the diagnosis. It's a case of leishmaniasis, but we are at the beginning of the problem. There's no systemic or kidney damage. That's good news all the time. There's no big gamma globulinemia. We have a mild increase in beta globulin, but that's all. So it's true that we have, if you look here, we have an increase in beta globulins and in gamma globulins, but not terrible. This is the result of the culture. Staph intermedius, Clostridium perfringens. We know that no fungal culture positive. So these are probably just contaminants living in the skin. So I'm not concerned about that. I'm going to ignore, to neglect these two guys. And this is all biopsy. And so this is one of the nodules, the nodule with the intact epidermis. I don't take the sample from the middle of the nodule that is ulcerated. This is one lateral side. And you see that the epidermis is moderately hyperplastic, and there is a diffuse inflammation in the dermis that is mainly macrophagic with some plasma cells and some lymphocytes, but basically it's a granulomatous inflammation. It's not neoplastic. That's good news. It confirms the serology. I don't know if here in this chaos there are some leishmania. This could be one. So these dots. But it's very difficult on the hematoxylin eosine in many cases to detect the parasite. We could not see the parasite either in the cytology. So it's very difficult. I also think that if this is it's a granulomatous reaction, but in some cases, you see, these are all macrophages, but you can see, like here, for instance, a mitotic figure. So in some cases, in the granulomatous reaction, there is some mitotic figures, so you have to do good. The best thing to really identify the parasite in the skin biopsy is to use immunohistochemistry. So use an antibody against leishmania, and then you will see the dots in brown. So here you see one leishmania here, another one here, another beautiful leishmania here, another one here. So you see that it's not a big parasitic load. We are at the beginning of the process. All the data that we have suggest the same. AIDS leishmaniasis is a local infection, quite well controlled. We have a good chance to treat this dog. So the prognosis should be good. So we diagnose nodular leishmaniasis stages 1, 2. We know that it's systemic, that both ears are infected. This is not the site of the sandfly bite, but it's quite restricted to the skin. What we have is a granulomatous dermatitis due to leishmania infection with very low number of leishmania organisms and a low antibody titer and a serum protein electrophoresis showing increase in beta and in gamma globulins. So all of this information, it's useful to make a prognosis. Say to the owners, we're going to control this. I think that it's no kidney damage, no other severe diseases. This was the treatment. We started meglumine and timoniate once a day. This is about 80 milligrams per kg. 4 weeks, allopurinol, 200 milligrams twice a day, and then control the ectoparasite. A good diet. We in some cases recommend a low urate diet because allopurinol can cause shunted urolithiasis. So it's quite important to pay attention to the diet. Don't give home-cooked diet with a lot of meat or some uncontrolled food. And then we start the follow-up visits. And then after 6 weeks, you will see marked clinical improvement. They almost disappeared. The analyses are good. Remain positive. So even is more positive than at the beginning. So this is normal. The antibody titers move very slowly. So remember that we check for IgGs. Immunoglobulin G lives about 4 weeks. So when you start to produce them, they have a long persistence. You still produce, and every molecule lasts for 4 weeks. So the titers don't change in 2 weeks. Here's our patient. You see the nodules are almost completely gone in 6 weeks. It's improving a lot. I'm happy. You see it's doing really well. This is the serum protein electrophoresis. Still pretty high, 8, but almost within normal values. Still the beta and the gamma are high, but albumin is good. I like this. A 3 of albumin is good. No leaking albumin to the kidney. That's good news in general. So this is later, after 6 months, you will see no clinical signs. Everything is normal. The antibody titer start to go down and the serum protein electrophoresis is normal. Here we have a normal, after 6 months, a normal serum protein electrophoresis. You see quite normal in beta and gamma, completely normal. The values are within the limit. So 0.56, it's within the limit. The beta is inside the limit already. The albumin is 3.6, great value for albumin. Albumin is a reverse acute phase protein, so high albumin means no inflammation at all, so it's good news too. And here's the dog with no lesion, beautiful ears, doing relatively well. That's how you should treat and control the patient with leishmaniasis. Finally, let me give you just a couple of recommendations about preventing leishmaniasis, because we have now tools to prevent the disease. And basically, we have 2 different tools. One are tools to prevent the infection, and this is the use of topical insecticides. And then we have interventions to prevent the disease progression. And these are vaccines. We have 2 vaccines in Europe, and then we have also some immunomodulating drugs that help to prevent the progression of the disease. This is vaccination. So the first tool that we have are the topical insecticides that prevent the sandfly to transmit the disease. And this has been well investigated and proved with pyrethroids. that have two different effects. One are repellent, so if your dog is treated with pyrethroids, deltametrin, permethrin, or some others, the sandfly, when it's approaching the dog to take a blood meal, feels that there is this chemical and doesn't go over the dog, simply it's repel and doesn't bite the dog. Also, these insecticides have a killing effect. If the sandfly finally decides to stop on the skin of the dog by contact or by ingestion, it dies. Of course, it's better to be repelled because if the sandfly has a time to bite, it can introduce the parasite, so it's not a complete protection, but we know that using these insecticides, either on collar, as a collar or as a spot on or a spray, you reduce the sandfly bites and the transmission of the promastigotes of leishmania. You can say, how you know that? Well, there are very good scientific data. This has been very well investigated. It has been investigated in laboratory studies, so using the insecticide on dogs, on a chamber, on a lab, to see how many sandflies bite the dog after applying the insecticide as a collar or as a spot on. And also there are many field studies showing that when you use this insecticide in dogs living in an area of leishmania, the probability to develop leishmaniasis is reduced. So I think it's a very good alternative. And the recommendation is that all dogs living in endemic areas of leishmaniasis or limit areas of leishmaniasis should be constantly under the protection of topical insecticides. You can use a collar. I think that you have here the Ceresto collar. Bayer, you have that one? Ceresto? Foresto. It's called Foresto, not Ceresto. Yeah. Foresto. Contains flumetrin and imidacloprid. That's very good for protecting leishmaniasis. Or you can use the spot-on, like Advantix. Do you have Advantix? Yeah. These are these. So, in theory, all dogs living in endemic areas should be protected with that. If you have a dog that is going to visit an endemic area, you should recommend the use of one of these two measures, or the collar or the spot on. And the recommendation is that start to use the collar a few days before departing to the endemic areas, because in some cases, especially with the collar, with the spot on is faster, needs a few days to spread all over the skin surface, to load all the skin surface. And then if your patient has been in Italy, Spain, Turkey for a period of time, I will recommend to check for leishmania between 4 to 6 months after the visit. Because if you test the dog 1 week after visiting endemic area, usually are seronegative. It needs time, the disease to develop. And it's recommended to do the test after 4 to 6 weeks of visiting an endemic area. There are another group of treatments or strategies to prevent the disease progression, and these are the vaccines. There are 3 vaccines for leishmaniasis in the world, 2 in Europe, which is this one, Canine and Letifen. These 2 are sold in Italy, France, Spain, and this one is sold in Brazil, where they have leishmaniasis too. The vaccines that we have do not prevent infection. So vaccinated dogs develop the infection with leishmania. But after the infection, the immune system is able to control better the infection than in dogs without the vaccine. So you do not prevent the dog to be infected. You simply make the disease less severe. In many dogs, they do not develop at all the disease. In some others, they develop a milder disease. And this has been relatively well investigated. And then the efficacy of these vaccines is around 70%. So when we vaccinate dogs against leishmania, I explain to the owners that this is not a 100% protective vaccine. It's not like distemper, and that protects very well. If you do a very good vaccination of the dog, it's very, very uncommon that your dog develop distemper after good vaccination with a good vaccine. It's more like other vaccines that we have, like a kennel cough vaccine. It helps, but some dogs develop kennel cough. Or the flu vaccine in humans. This year, the vaccine for flu was not very effective. It has a protection of about 30%, because the strain of the influenza was not very susceptible to the protection of the vaccine. So we see protection around 70%, which is good. It helps. The data suggests that the probability to develop clinical leishmaniasis if you are vaccinated is 4 times less than if you are not vaccinated. So I mean, you reduce by 4 the risk of developing clinical leishmaniasis. You have to choose if you want to do this or not. It's every year. It's a vaccine. So we have these two in Europe. This is a Canine, it's produced by Bilbao. This vaccine needs 3 doses the first year, separated by 1 month, and then every year 1 vaccine. This one needs only 1 dose, and then repeat the dose every year. And that's the situation. So I explained to the owners that it helps, and if you want to use it, the dog is more protected than without vaccination, but has a cost. Right? There's a big discussion about using vaccine in endemic areas. So the cons of that is that it's not very effective compared with other vaccines. We do not have, the vaccines are really new. We don't have what we call phase 4 clinical trials. So it would be nice to follow what happened with the vaccinated dogs after 3 or 4 or 5 years. How many of them? Because the data of the efficacy of the 70% was published based on studies done before the launching of the vaccine. And I would like to know exactly on the general population how effective they are. And some of them have side effects, mainly pain at the site of the injection. Of this vaccine, of these 2 vaccines, this one, Canine, causes a lot of pain on the inoculation side because it contains a very strong adjuvant. So they feel like inflammation. And in most cases, the veterinarians in Spain or in Italy, they give the vaccine together with a non-steroidal anti-inflammatory drug. So you give a Itacam or whatever at the same time, just to prevent a little intense pain after vaccination. And the cost is also a problem. It costs about 150 euros. So it's, I don't know in your currency, but it's expensive. So some people don't want to. The pros are that they reduce the risk to develop clinical leishmaniasis, and it can be used together with insecticides. So what I recommend to my patients is first use the insecticides all the year. This is very important. If you want to do more, you can add the vaccine, but don't use the vaccine instead of the insecticide. Because also, if everyone is using insecticide, the transmission of the disease drops in the area because there are less mosquitoes or less sandflies going from one dog to the other. So every year you have less and less leishmaniasis. So we have the recommendation is to encourage the use of insecticides, and in addition to that, if you want to reinforce the protection of your dog, use the vaccine in your dog. So in endemic areas, we recommend vaccination in addition to the use of insecticides. Especially, I think that some dogs are more likely to be good candidates for vaccination. For instance, if you have a very young dog, all dogs that have been living in Italy for 10 years, probably are already infected. And they are doing well. They are controlling already the disease. You don't need to help them. But if you have a very young puppy that is new in the area and is exposed, maybe you can help the immune system with the vaccine to prevent that he or she develops clinical leishmaniasis. Also, we know that some breeds, German Shepherds, Boxer, Rottweilers, are clearly predisposed, and also dogs spending a lot of time indoors. If you have a very small Pomeranian living in an apartment in the 10th floor that never goes outside, probably not necessary to consider vaccination. On the contrary, you have a German Shepherd that is outside, outdoors all the time, and is young, living. You can recommend with more basis the vaccination. Should you recommend to your clients to vaccinate the dogs when they go on vacation to the endemic areas? No, I don't think that you have to do this. I don't think that you patients, if they go to Turkey or Italy or Greece for a few weeks or a month, they need to be vaccinated. I don't think that this is adequate for this dog. I think that what you have to suggest is to use a good insecticide to protect them, either the collar or the spot on, to cover all the period of time. And when they come back, you can test with serology to be sure that the dog has not got the disease. The same, if someone is coming from one of these countries to see you, you can check if the dog is seropositive to do a more accurate control. If the dog is seropositive, you know that this dog is infected, and maybe every year when you do the recheck, you can check that the titer of leishmania is not going up and that everything remains under control. But that is all that you have to do. You have questions about leishmaniasis? Yes, you have one.
Immunosuppressed dogs, do you recommend vaccination if they live in the endemic area?
In theory, the vaccine is recommended for healthy and seronegative dogs. So before vaccinating a dog, you have to double check that it's seronegative for leishmania and that it's healthy. So an immune suppressed dog will not be a candidate to be vaccinated.